Hello and welcome to yet another useless Q&A. 500,000 subscribers. I mean, wow, what a landmark. Thank you to all of you for not getting me there. No, as I record this, I'm languishing in the 490,000s. Thanks for that. I grossly underestimated the amount of time it would take to go from 490 to 500,000. Subscriber growth appears to have just ground to a halt. I guess I should be worried about that. Irrespective, the main reason I'm recording is because I put out a request for Qs for the Q&A via my newsletter, Nebula, and then the YouTube community tab. And so much time has now passed, it's frankly embarrassing, so I figured I'd just have to go ahead. Besides, interventional cardiologists are renowned for being particularly impatient, so this is really just on brand. I'm going to prioritize questions from newsletter subscribers and Nebula subscribers because, I can, and it's just not a fair world. But I needed some help collating all the questions because they're from different sources, but I haven't seen any of them yet. So let's get cracking. First question. Sugared Oleander asks, you've inspired me to go to medical school and I just got in. Congratulations. Now, how do I not die in the next 6 to 13 years? Well, that's easy. Just die in the next 5. Chris asks, why are we still not very good at predicting heart attacks? Well, that's a great question. And perhaps what Chris is referring to there is that there is a fundamental mismatch, or there's no correlation between the amount of narrowing in a coronary artery and the risk of developing a heart attack, which might sound counterintuitive. But you might have an artery which is 90% narrowed, so only 10% of the lumen is left. But it's built up slowly, the narrowing is very hard and calcific, and it's stable. It may cause angina, it may cause a lack of blood flow causing pain, but it won't rupture and become a heart attack. Whereas you might have narrowing which looks quite mild, maybe 50% narrowed, but it's an unstable plaque, and plaque is the term we use to describe these deposits of cells and cholesterol and things like that. And if it's got a thin cap and it's unstable, it ruptures that cap, all that cholesterol-rich core comes out, causes the blood to just completely have a panic attack and clot everywhere, then that is obviously a much higher risk lesion. So we're not good just by eyeballing them. That's not going to work. There are techniques that can identify high-risk features, but at the moment they're limited to research facilities. They're very high-tech, specialized kinds of scans which haven't made their way out into general clinical practice. We are starting to see the beginning stages of this, and some things are filtering out. That's the nature of how these things work. So there are techniques to do it, but at the moment they're very specialist, but they will start becoming more commonplace soon. Phi TSF asks, how often is turning it off and on again a sound medical solution? Well, that is essentially what we do in a procedure called cardioversion. It's a very routine procedure in cardiology where somebody's heart is beating irregularly. It's in a kind of chaotic rhythm. We bring you in, put you to sleep, give you an electric shock in a controlled way, 360 juicy joules of biphasic shock through the heart. And what that does is interferes with the chaotic rhythm, breaks that all up, puts everything into sort of stunned disarray for a second, and then the intrinsic pacemaker system of the heart kicks in and takes over. And then you wake up and you've been reset. Noor asks, tips from a failing cardiologist on how to... Tips from a failing cardiologist on how to approach year 1 of medical school. Well, I would start, Noor, with maybe not insulting the people who are supposed to be teaching you. Andy asks, he starts by complimenting my joke. I didn't need to mention that, but I thought it was important. You have a clear interest in debunking pseudoscience, medical claptrap, and related nonsense. Why aren't more doctors of science-based medicine as aggressive as you are, especially when it's clearly abused from within your own industry? I would push back on that slightly. I don't think I'm unique in any particular way. I think the vast majority of my colleagues are just as vocal and want to help their patients just as much, reject pseudoscience, and will be just as critical of non-science-based things. Don't forget that a doctor's main job is talking to their patients individually. My role as a kind of public educator is unusual, but my main job, doctor's main job, is talking to their patients. So we all, I think, say similar stuff. But okay, I will concede that maybe there is a bit of a blind spot in a lot of medical practitioners' eyes of maybe dichotomizing artificially between the alternative medicine, the quacks and the homeopathy and the chiropractic and all the kind of hocus pocus stuff, versus real medicine. And actually, I don't think the line is always so black and white. I think there's a lot of stuff that we do in medicine which is regarded as real science, which is actually based on pretty shambolic evidence. And there's a lot of things. I mean, there's a litany of medical therapies that have been abandoned when it became apparent that they didn't work, or even worse, that they were doing harm. The Bob Brom says, as a cardiologist, hopefully you'll be able to give me your medical opinion on this. Is a dream actually a wish your heart makes? And if so, why does my heart wish me to be eaten by giant killer cabbages? Well, Bob, when your heart is severely diseased, when you have severe narrowings of your coronary arteries, we refer you for open heart surgery, an operation called a coronary artery bypass graft, CABG, or cabbage. And we say, well, patient is going to have a cabbage. So when your dream, which of course, as we all know, originates in the heart, is telling you that you are being eaten by giant killer cabbages, I'm afraid, Bob, this implies that you have critical heart disease and you need to get yourself to a hospital ASAP. I'm not joking. This is a very common thing. We see it a lot. I want you to walk in there, bang on the table, and tell them about your killer cabbage dream. I guarantee they will fast track you somewhere. Alex asks, how do you reconcile informed consent and shared decision-making with the fact that almost no patient truly has a full understanding of what they're consenting to, risk, reward, realities, and so on? That's an excellent question, and one I've actually been discussing quite recently with some colleagues, because we were talking about how procedures that I do in my subspecialty of interventional cardiology, my colleagues who are also cardiologists but in a different field don't even understand. So and vice versa, I don't understand all the things they do in their subspecialties. So if cardiologists don't understand treatments other cardiologists are doing, what expectation do we have that a general physician, a doctor in another field will understand, leave aside a member of the public who may not have medical training? So absolutely, the concept of informed consent, I think, to be honest, is a bit of a convenient fiction that we tell ourselves. The other point here about shared decision-making is I read an editorial recently which prompted the conversation I was having with friends about moving away from the old-fashioned model of medicine, which was a paternalistic, doctor knows best, do what I say model, which obviously is wrong. But the author was arguing that we have moved too far in the other direction, that we are now involving patients in incredibly complex decisions, which, as you suggest, they don't have a chance of really fully understanding. And when you are deciding about yourself, you are inherently, it is obviously going to be emotional, so it's even harder to be neutral. And a clear example of this, in my opinion, is resuscitation. As you may have seen in one of my videos about death, resuscitation is not that kind of binary live-die outcome. And people have a very unrealistic view of resuscitation based on TV and movies, and this has been shown in surveys. We are now told to discuss, this is in our guidelines, to discuss resuscitation with patients and their families. And obviously that's fine to do, but it can lead to situations where the treating team will feel that resuscitation is not in the patient's best interests, but the patient and their families might think, why is the clinician wanting to deny me this life-saving treatment? Not aware of the fact that actually the most likely outcome from a cardiac arrest is just a very unpleasant last few minutes of life, or to survive the cardiac arrest but have a significant disability, neurological deficit, not be able to talk, speak, breathe. There are so many outcomes that aren't the same as just walking out of the hospital. So I think it's a really interesting point. I think there's a lot to say about that. In practice, most of the time, it's okay, because I think patients, I give them the information, but a lot of the time they end up asking me, Doc, what would you do if it was you? What would you do if it was your loved one? And I often ask myself that as well. I'll often say, if this was my family member, what would I recommend? And a lot of the time, patients do actually want the physician to give them a recommendation. We're never going to force a patient to do anything, but I'll say something like, look, in your case, I think not having the operation is actually a better thing to do, or whatever. Fuchs, as a cardiologist, what's your preferred way of ending a life? Well, call me old-fashioned, but I generally try not to end my patients' lives. I know, controversial. So let me flip the question. I will say, as a cardiologist, what are the ways a patient can die that we really dread? Because obviously all doctors can make mistakes, and we can prescribe the wrong drug or something, but what is specific to cardiology that really terrifies us? Now, in my field, I'm poking a lot of stiff and sharp things through coronary arteries and inside the heart. So perforating something is bad news and often a complete disaster. Bleeding, then the patient will bleed internally. That one's pretty obvious. So I think maybe most people could have guessed that. So perhaps I'll say a different cause of death that you might not have heard of, which certainly as a training doctor you're petrified of, because you're normally not the one poking the sharp things. You're normally the one injecting the contrast, which is the X-ray dye. And if you're not meticulous with not allowing any air into the syringe, you can get what's called an air embolus. You can inject, a whole syringe full of air, or worse, I've not seen this real life, but I've seen it online, a power injector, like a big machine, injecting a huge volume of air. And any engineers watching or plumbers, you won't need me to explain that air in a pressurized hydraulic system is a disaster. And so if air gets into the heart, it can completely stop flow down the coronary arteries, because it will sit there. The bubble will sit in the coronary arteries, and the whole volume of a coronary artery is small. So even a small amount of air can be catastrophic. I've seen it happen. It invariably causes cardiac arrest. It's normally not fatal, but it can be. And it is every cardiology fellow's absolute nightmare to cause that. Maria asks, do people in medical school genuinely like anatomy? No. Nafi Iftekhar asks, does the heart actually want what the heart wants? Yes. Patrick asks, what is something you learnt as indisputable fact in medical school that has since been proven to be completely wrong? It's another nice question. Well, there are a lot of answers I would give to begin with, which are probably a bit niche and really only going to be of interest to medical practitioners. Things like fluid resuscitation in critical care, cooling after cardiac arrest, some of the drugs we administer in cardiac arrest. But probably a lot of you will be expecting me to say something along the lines of diet. And I think that is true, but I think there's also a lot of myths about what doctors get taught in medical school. You've probably heard this trope that goes around, doctors only get 1 hour of nutrition training. And people who say that generally have an agenda. Of course, it is true that some medical curricula don't focus on nutrition very much. I mean, we're not learning to be dietitians, but that's like saying, I only got 4 weeks of cardiology or whatever it was at medical school. It's like, yeah, but I have learnt a lot of cardiology, and those of us in fields where nutrition is relevant, which is a lot, obesity, vascular, diabetes, cardiology, renal, obviously gastroenterology, so many fields, you learn postgraduate. In fact, you do the vast majority of your learning after medical school. And I think people who claim that everything's been turned on its head, again, are not really aware of the evidence. There are still plenty of things that were taught when I was at medical school which are still reasonable advice. Things like having complex carbohydrates rather than refined, and managing your fat intake. But I think what has changed is our understanding of fat a bit better, in that I think most people are now more aware of the different types of fat, and just focusing on zero fat, which definitely was promoted. And certainly my mum's generation, my mum would, no matter how much I tried to tell her, to her, buying a 0% fat foodstuff must be better, must be healthier than something which has got some fat in it. And that was something that was starting to change when I was at medical school, because, of course, a lot of these 0% fat foods have loads of sweetener or sugar. So I think there's a much more sophisticated understanding of the kind of makeup of foods. And I think people now understand that you can have a diet which is high in fat, which is still perfectly healthy. And, one size doesn't fit all. Dr. Sally LePage. If you die, can I have your organs, please? No, Sally. I mean, I've spent a long time building up this collection. It's temperature controlled, it's humidity controlled, and I've got no paper trail. I don't want the authority. Oh, you meant the organs inside me. Actually, don't put this one in. Vincent asks, what is a medical story that you know of where if you told physicians they would laugh, but us common folk would find terrifying? There is, I don't think anyone would find this terrifying. In fact, I'm sure a lot of you will find it amusing, but also pretty disconcerting when you think about it. Okay, story time. So I'll take you back to my F1 year when I was an intern. I was first year, and I was working in a surgical firm, and it was a really old school surgical job in an old-fashioned department. So basically, all of the consultants were middle-aged or older white men, and they were this huge group that, we worked like crazy. Like, I'd be in before 6 a.m. I used to know all the patients inside and out, and we had so many patients, and we'd have to present everybody. They worked us hard, but they were also a lot of fun, and I had a great time on that job. And every Friday, they would buy us a massive fried breakfast after our ward round, and I'd been up since like 5:30 or something, so I devoured this stuff, and they liked me because they'd never seen someone who could eat so much. They'd, tell us interesting stories, and like how one of them had his gastric band loosened because he just wasn't enjoying life without, 10 sausages on a Friday morning. And one of them was, out of these bunch of eccentrics, the most eccentric. And I won't say his name, but he was very senior rank in the British Army, so we just knew him as Colonel. Let me paint a picture. He was not a big guy, similar size to me, very average, but he had 2 shocks. I won't even say caterpillars, they're like porcupines of silver hair above each eyebrow, above each eye, and he wore a pinstripe suit all the time, double-breasted, and I'm not talking subtle pinstripes, like the boldest, fattest pinstripe, but his pockets were always full of, I don't know what, battlefield metals and shrapnel or something, and so he walked around with his hands behind his back the whole time, and we used to joke that he thought he may be still on the battlefield. So, I'd say to him, Colonel, this patient is day 2 post-op, and their hemoglobin's, going down slightly, their blood pressure's dropping. Shall I organise a blood transfusion? And he'd say, boy, we need 2 bags of albumin now, and flying squad blood. And flying squad blood is O negative, emergency blood. And I said, we've got a valid group and save, we can just get some blood. And he said, albumin and flying squad blood right now, son. And there were 3 stories that I like to tell about him in increasing order of hilariousness. One was at the Friday fry-up, where he was talking to one of the other consultants, and they were all very posh and amusing. And one of them said to the other, goes, obviously he didn't call him Colonel, he gave him his actual name. He said, I hear you're off to Helmand province in Afghanistan. Isn't that awfully dangerous? And he just went, Thaddeus, it's what I do. The second story was about a middle-aged woman who was extremely anxious. And a lot of the time in general surgery, you get patients who've come in with abdominal pain. And a lot of the time, you can't actually explain what's going on. You rule out serious pathology. So she had had a CT scan, she'd had a colonoscopy, maybe upper GI endoscopy as well, and eventually she'd had an exploratory laparoscopy, so little cameras put inside through the skin. So she'd had the works. It came back negative. She was, just a bag of nerves. So we are presenting her on the ward round saying, this is Mrs. So-and-so, everything has come back negative, she should be good to be discharged home. And he said, excellent. And she was, saying, oh, I feel like such a fraud. I've wasted everybody's time. And he said, no, nonsense. And then, without changing his facial expression, just put his hands around her neck and pretended to strangle her and said, off with her head! And just then left us to sort out this sobbing mess. The number one story, another young woman who was maybe 20, and she'd come in with appendicitis. And in those days, it probably wouldn't happen now, the SHO, who was maybe 3 years out of medical school, and me, we did the whole thing ourselves overnight. So, I assisted him with the appendicectomy, which is the correct term, by the way. It all went fine, and a couple of days later, she was ready to go home. Now, just imagine, you're a young woman, you're surrounded by a huge group of mostly men, so you're already feeling so self-conscious. She's got her t-shirt pulled up, somebody's feeling her tummy, she's fine, she's going to go home. And he said, oh, splendid. And he was just turning to go away, and we thought, phew. And then he looked at the name above the bed, and, the consultant that the person is under, the name is written there, and obviously it's his name. And he said, my team have dealt with everything. You have come into hospital and been fixed and had a wonderful result, but you'll go home with my name on your paperwork, and I haven't touched you once. And we're like, uh-oh. And then he just went, calm as you like, and just poked her in the belly button with 2 fingers and blew a raspberry. Jonas asks, other than as a researcher, where will my previous experience as a garbage collector aid me in the medical profession? Well, journal editor seems obvious. Ranjit asks, what do you feel about patients researching their conditions online? Well, where do you think I research them? How has it impacted their treatment and their relationship with you or other doctors? I think is it like a medical meme or trope, don't confuse your Google search. I don't know any doctors that think that. Patient who is knowledgeable about their condition is great. Very occasionally you'll have a patient who, has no interest in what you're saying and just wants you to agree with them. And the vast majority of time, a patient is coming to you for advice. And if they bring more information with them and they're saying, hey, doc, what about this treatment I read? This could work. That's great. It helps me keep up to date. So, I think most doctors are very happy. And again, we mentioned chronic disease earlier on. When it comes to chronic disease, and particularly ones that the average doctor is not going to encounter very often, the patient's going to be far more knowledgeable. A good piece I read a little while ago about a lot of awareness campaigns for, something rare like motor neuron disease. It was saying that actually the average general practitioner will see a handful of cases in their whole life. So these campaigns to be aware of different diseases might not actually make that much difference because they're so uncommon to an individual practitioner. As a population level, there are obviously thousands of people suffering from them. But if you take a single general practitioner, and obviously they're the people making a lot of diagnoses in the population, they're just simply not going to see that many cases. Christopher asks, when are you going to show off those sweet dance moves? And Burhan Budak asks, you said you would never give us medical advice casually, but could you give us dance tips? Any secret forbidden moves? I think, guys, I'm too old. I've put a couple of videos on TikTok in the last few months, which I haven't done for a long time. No dancing, I'm afraid, but maybe that's a segue. I actually think vertical video has been a tremendous net negative on humanity, but also on dancing. I think, okay, I'm going to say it, it's my hot take, Gen Z are worse dancers than millennials. Okay, and come at me, because I'm going to back that up. Vertical video, I think, has been a disaster. Real dancing, breaking, deserves landscape. Forbidden moves, I always thought I could never do it, but if you're like in a planche or, a turtle, like some kind of float, so your hands are on the ground, your legs are in the air, and then you go clear, and you push yourself up in the air and land back on your hands. That's called the defibrillator. Philip asks, do you recall why you started a YouTube channel? Are you at all proud or feel any sense of accomplishment? I don't know why I find that funny. I think that might be the first time I've laughed on this channel. I don't know why I find that funny. Are you proud? Do you feel this is some kind of accomplishment? No, I don't really feel any pride in any way. I love that I've got this channel. I love what it's done for my career, and it's made my life more interesting and more enjoyable. So I'm 100% committed to keeping it going. But I don't know if pride is the right term. I mean, it's just a load of nonsense, really. Why did I start a YouTube channel? I guess there were two reasons. One is a little sad. I mentioned my mum. She was very sick, and so I had just taken a complete break from my PhD, and I just going to look after her for her final year of life. And so I was spending a lot of time with her, and obviously had more free time as I wasn't working. And I'd always had this interest in making videos. And my biggest regret, in fact, I'm not someone who regrets many things in life, but one of my biggest regrets in life is that I just wish I'd started sooner. Because I had the idea, I even had some camera equipment. At medical school when I started, YouTube didn't exist. And I made some silly movies with a friend, the usual kind of horror schlock. But then we entered some film festivals. We were shown in cinemas in East London. And then we entered a 1-minute film competition, TikTokers before it was even a thing, and won. And we got an amazing broadcast quality camera. And then we just didn't do anything with it. I guess I got busy with my career, normal career. But that is a big regret. I would show some of the clip to you. It's got copyrighted music. But okay, I'll show you a little clip now, and then I'll put the link below if you want to watch the rest of it. And the other reason I started a YouTube channel was because I've always done kind of public speaking events and told jokes and done some sciencey stuff, and a friend of mine just said, why don't you put that on video? Graham asks, over the years I've seen many medical professionals gain some amount of celebrity status, and everyone that I can think of has started off as a solid mainstream professional and then slowly drifted into more fringe or clickbait thinking. What are your thoughts on this, and are you planning to I thought it said are you planning to do it? Yes, absolutely. Wait, my diet plan coming soon. I completely agree with you, Graham. It's a phenomenon. In fact, I must write this in maybe one of the newsletters rather than a video. But I have observed this phenomenon, and I've been collecting a lot of examples of exactly this. Podcasters, YouTubers, even tweeters who start, if not mainstream, but at least reasonable, but a lot of the time start entirely sensible, just giving normal advice. But you don't tend to build an audience with normal advice. And then they start pushing slightly more edgy stuff. They see their following grow, and then they get further and further and further. And this is sometimes referred to as audience capture. I guess it is analogous to any field, politics or whatever. But in medicine, I find it particularly interesting how people can start being fairly sensible and quickly promote complete hogwash. And I don't know if it's purely cynical or whether they're just incredibly stupid. I just went on a rant where I named a whole bunch of people, YouTube channels and podcasters and things. I've decided not to put that on YouTube, but maybe I'll put it in a future newsletter. Septimus Productions asks, I heard from a Veritasium video that apparently newly graduated doctors are better at diagnosing rare diseases than experienced doctors, and was curious whether this is a weird statistical thing or something you've experienced in practice. Your diagnosis of Texas yellow nail fever comes to mind. That's pretty impressive if you remembered that. You didn't quite get the name right. Veritasium or otherwise, all I would say is don't believe any single source. There have been some things in Veritasium videos which have not been true. But obviously, on the whole, amazing videos. And I've seen that one, so I know what you're referring to. I don't know the study it refers to. I wouldn't be surprised at all. But that's natural, isn't it? So that yellow nail syndrome that person's referring to was when I was a few years out of medical school. I was deep into my postgraduate exams, which is kind of like our board exams, MRCP, and had all that book knowledge in my brain. And of course, and we used to joke that, isn't it sad that this is the peak of my general medical knowledge? And that is the case unless you are going into becoming a general medic afterwards. But if you become a specialist like me, then of course I'm going to forget a lot of those weird and wonderful things because I just am never going to see them. But one would hope that my cardiology knowledge is superior. So when it comes to rare cardiology diagnoses, I should be performing better than someone fresh out of medical school or doing their exams. But your general level of knowledge will be better, and then you become more focused as you become a specialist. Or obviously there are generalists like family doctors and general internal physicians and so on. Paige V asks, it seems a relatively low resting heart rate is an indicator of good health. That's correct. However, how low is too low? Well, 0. Dan the Dude, with chronic illness and diagnosis, patients often need to advocate strongly to avoid having symptoms dismissed. In your opinion, where's the line between patient advocacy and getting a second opinion, or doctor shopping and looking for what you want to hear? Excellent question, and that's coupled with a question from Tate. Getting a second opinion seems commonplace in the US, whereas in the UK it's generally not done. Do you think it's something patients should be doing, or do you think diagnoses should be considered final? Great pair of questions with sort of linked things, so I'll try and answer them together. I think there are a couple of issues here. One is seeking a second opinion as a patient in somewhere like America, where you're effectively a consumer. So it might be quite normal to seek one opinion and get a plan, and then find another, you get a different plan. And your decision about who to go with may be based on insurance, based on what you can afford, based on what is offered. Whereas in the UK and socialized medical systems, typically you're just going to see one specialist, and if you want to see somebody else, it's because there's been a problem with the care, like you're not happy with the care. And of course that happens, and that's perfectly fine not to be happy with your clinician. And in those cases, I promise you, none of us are going to take offense. If somebody were to say to me, look, I'm not happy with what you've told me, I'd like to see somebody else, I would absolutely welcome that. No doctor is going to take that as an insult. I would say, sure, I'll recommend this person. They're a expert in this field. Because you see, what we do a lot of the time is seek second opinions ourselves. So it's not coming directly from the patient, but say I've got a complex decision to make. I will take this to something called a multidisciplinary team meeting. And there'll be other doctors there, cardiologists, surgeons, nurses, physios, whatever, depending on the meeting. And we'll discuss the case and we'll come to a consensus decision. And that not only is better for the patient, good practice, but it's also better for me, because later on, if something goes wrong, the patient can't say that I was acting as a sort of cavalier, unilateral decision maker, when I have sought the opinion of my peers. So getting a second opinion is totally normal within medicine as well. But yes, from the way the systems are set up as a more commercial, private enterprise in America versus the UK, getting a second opinion as a matter of routine is less common. But by all means, if you're not happy, don't feel that you have to be stuck with a certain clinician. You can always ask for someone else. I'm not saying you won't have to wait or anything like that, but it's entirely your right. Cheeky Chappy 1234 asks, if a consultant, a junior doctor, and an undergraduate doctor walk into a bar, who buys the beers? I mean, this isn't very realistic. I wouldn't be fraternizing with subordinates. PJK922 asks, what is one diagnostic tool or test that you wish you had but doesn't exist? Nice question. Maybe just like some device that we scan the patient and it gives us their 1, 3, and 5 year mortality. It won't say what they die from, but it'll say you have a 95% chance of being alive in 1 year, and 70% 3 year, and 20% at 5 year, or something like that. That would be really useful. If your 5 year is 90% or more, I'd just say, off you go. I don't want to see you. Blue Pepper asks, what progress has there been in acknowledging that heart issues and heart medication work differently in men and women? Well, this is a reference to a lot of work in recent years that heart disease manifests differently in women, which sometimes I feel that message has got a little bit miscommunicated. In the majority of women, heart disease still does present in the same way, but there is an atypical presentation in a lot of women as well. And there's been a learning process across the board of how to recognize some of these signs in women. A lot of research was done in men. So what has been done to rectify this? Well, actually, in recent years, there have been some really positive movements when it comes to research. When you're putting together a research study now and recruiting participants, depending on the type, you have to guarantee that there will be a certain proportion of women. I think it is a third. You might ask, why is it not 50%? But men, particularly young men, tend to put themselves forward as volunteers for a lot of these things most commonly. So there is often a sex skew in terms of who is volunteering, but obviously you can actively try and recruit other kind of people, and you have to have different ages represented now, more real world populations. If you test your drug in a bunch of 50-year-olds and then you go and prescribe it to 80-year-olds, then you haven't really got the evidence to say that, and different ethnicities as well. So there have been positive steps, but yeah, I think, it's a long process, and a lot of these trials, their results won't be out for many years. Laurie in Japan asks, eat like a pig and exercise a lot, or eat sensibly and never leave the sofa? Which one will destroy my heart quickest? I think if you never leave the sofa, no matter what you eat, I think you're going to be worse off than someone who does a lot of exercise, even if they're eating junk. And I don't know, how much junk they're eating if they're able to exercise a lot. They must be at least meeting some kind of nutritional demand. But if you're moving about a lot, you're going to have better cardiovascular fitness, probably better bone density, lung capacity, balance. All of these markers of frailty will probably be better if you're moving around a lot. Now, you've heard the expression, you can't outrun a bad diet, and that's true. I'm not saying the other person is healthy, but if I had to choose, I would say that the person who never leaves the sofa is going to be worse off. Lucas asks, what do you think of using placebos, and how would you administer them? Lying to the patient sounds like a bad idea. Yes, lying to the patient is a bad idea. It's generally frowned upon. It's an interesting question, and one I've been asked before, when people say, I know it's wrong to lie to a patient, but placebos have this incredible effect. Why can't we use it in some way? And of course, some people do. Alternative medicine, I mean, that's what it is. It is a way to capture the placebo effect. And that's why, I often say I'm sympathetic to the existence of alternative medicine. But that doesn't mean we can't try and utilize some of that in conventional medicine as well, because every drug, even if it has a proven efficacy, it can also have a placebo effect on top. So when I take a paracetamol tablet, I know that there is a clinical effectiveness borne out in studies with other people. But in my head, it's a wonder drug. It's going to make me feel incredible. It's this super special tablet which is going to get rid of whatever pain I have, particularly if I have a headache. I find it is 100% effective. And that's a deliberate kind of extra placebo. When I do angioplasty on someone, opening up their vessel with a stent, you'd think that is just pure physical action. But we know from studies that there is a placebo effect on top. So I try and maximize that. Every time I finish the case, I show the patient the before of this ragged, narrowed artery, and then I show them the beautiful, pristine pipe afterwards, and I am full of praise. I'm like, look at this. Oh, it's amazing. What a beautiful result. It's like a wide open highway. It's like an 8-lane superhighway just delivering blood to your myocardium. Why not? I'm going to maximize the placebo potential, and I want them to get the most benefit from their treatment. Yeah, and I know I've said this before. I will make a video about placebos. Column asks, what are the top 3 most useless things I must know as an incoming FY1? FY1 is British for intern. So this is a first-year doctor, fresh out of medical school. We've recently had our F1s start in cardiology, and they seem like a lovely bunch. So it's always nice to get fresh fish straight out of medical school and mold them into jaded, cynical people like me. Useless. You want useless. Let me tell you some of the trivia then that I like to talk about on ward rounds. Intravenous drug users get infection in the heart, endocarditis. This is where you get a vegetation of infection on one of the heart valves. And any medical student or F1 will be able to tell you that you get right-sided endocarditis, right valves, right-sided heart valves, because the bugs hit the right side of the heart first, because you're introducing them in a vein when the people are shooting up with the dirty needles and getting infections in the skin. But then, why don't other endocarditis cases affect the right heart as well? Because where does the bug get introduced then? Normally in the teeth or from an infected wound or something. So it's also draining into the venous system. So why don't all endocarditis cases affect the right heart more than the left? Well, the answer is that endocarditis looks for areas of fastest flow, turbulent flow. So normally that's in the left side of the heart because the pressures are higher. But in intravenous drug users, what they're injecting is rarely clean. It's cut up with all kinds of things, talc, baking soda, all these kinds of fine particulate matter. And it's that causes the problem. So you get this micro trauma on the tricuspid valve, the first valve that it comes into contact with from the veins, and all this little grit and crud roughs up the valve and provides a perfect place for infection to adhere. But it doesn't go to the left side of the heart because all of that crud gets absorbed in the lungs. It gets stuck in the small capillaries in the lungs. So that's why intravenous drug users have right-sided heart valve infections more than other people. But they all come in through the venous system. Let's give some other useless things. Well, drug names is my other favorite trivia. You've probably heard of frusemide or Lasix because it lasts 6 hours. Another bit to that is the LA is also the place where it acts. Loop ascending of Onlay. Then what about the edoxaban, rivaroxaban, apixaban? They all block factor 10A, XA. So they ban. So that's why they all have XA ban in their names. Warfarin, another one that's probably quite well known from the Wisconsin Alumnus Research Foundation. Then nystatin from the New York State Public Health Department. Rapamycin, which comes from the native name for Easter Island, which is Rapa Nui. The first HRT was called Premarin because it came from pregnant mare's urine. Nitinol comes from nickel titanium naval observatory laboratory. Adrenaline is a cardiac medication we use to diagnose things like Brugada syndrome, and it was named after Hakim Ajmal Khan, who was a Unani doctor in the 19th century in India. It was discovered by Salim Muzamman Siddiqui. Rifampicin is named after a French film noir called Rififi. Sinemet, a lot of Parkinson's medications cause nausea and vomiting, but Sinemesis without vomiting, Sinemet, and Tadalafil comes from tada, here's a boner. Nix asks, blah, 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 have you been tempted to jump on the YouTube Shorts trend? You know, I have changed my opinion on Shorts recently. I mentioned that I've uploaded a couple as of late, which I haven't done for a long time. Don't worry, it's not going to be something that I'm investing a lot of time or effort into. I just don't have the time. I don't see a problem in doing it occasionally. I think it can be quite useful and fun. I generally don't consume a lot of short form video. I generally don't enjoy watching vertical video. And initially I was quite annoyed that YouTube were just trying to copy TikTok. But the more I've learned about TikTok, and I hadn't really engaged with it in any way, and I still haven't really. I think it's a net negative. I think it's a bad app. I think there's a lot of things to be suspicious of about it, but also it treats its creators very badly. I just, next to YouTube, I think it's chalk and cheese. So if YouTube Shorts can replace some of the TikTok market, I think that can only be a good thing. So I'm more receptive to it now. If you want to know more about this, Hank Green did a nice interview with Decoder where he talked about TikTok quite a bit. I mean, Hank does talk about TikTok quite often, and actually I think he's always got useful things to say about it. So some of what I've think is shaped by people like him. But in terms of this channel, I had made a shorts channel separately. I didn't really ever publicize it much, so it's kind of languished. What I'm going to do now, you heard it here first, I'm going to convert that to just a second channel, like a lot of YouTubers have a second channel where I can put whatever I like, and then I'll put the shorts kind of wherever seems appropriate. What is with reperfusion injury? The heart likes to cause quite a fuss when its blood supply gets cut off. However, when you give it what it wants and reintroduce blood, it complains even one can end up in a worse condition. I thought the heart was a cool organ, but it sounds like quite the crybaby. That's from Lewis G. Well, Lewis, it's not just the heart that has reperfusion injury. Actually, it's pretty much any tissue, but it depends on how quickly that tissue will become ischemic. So reperfusion injury is a fascinating concept, and actually my PhD was sort of in this field. So I could probably talk a long time about this. There is a very bizarre phenomenon where if you occlude the artery, you cut off blood supply, you cut off oxygen, so obviously then some damage occurs. But when you open up the artery again, so this is what I'm typically doing, then blood starts flowing to this ischemic tissue. That caused like a second wave of damage, which seems paradoxical. As Lewis says, you're giving the blood back, you're delivering oxygen, and it seems like the oxygen is probably the problem. Oxygen-free radicals, and there's a lot of complex biochemistry at play here, but there seems to be this second hit. So patients can often get worse when you open up the artery, and it's a really interesting thing. And my research was looking at ways to try and mitigate this, and doing certain interventions and scans to see if we could reduce the amount of reperfusion injury. Because we've become really good at opening up the arteries, but we haven't made much of an impact on the damage done by reperfusion. Michael Mayhem asked, since you mentioned tropical viruses, oh yeah, when I sent out the request for Q&A, I'd mentioned that I was in India, I've just got back. My whole family and me, we were all super sick with some awful virus. We all had temperatures in excess of 40 and just felt like terrible. That's probably, 15 flaming eagles. How do you feel about the fact that the medical and pharmaceutical industries largely ignore tropical viruses until they spread outside of the tropics? Do you think things will change, or do you think things will continue the same as always for the foreseeable future? What do you think I'm going to say? Not that I have developed a reputation as being a cynic or anything, but you know what I'm going to say. There is some horrendous statistic, like 90% of the ill health burden worldwide has about 10% of the pharmaceutical expenditure on it. If you make the only system fueling drug development, the vast majority of which does come from the United States, capitalism, you are only going to pursue treatments which generate the most profit. And so that means making treatments for people in affluent countries. And it's worse than just not involving the developing world. Often these trials, these companies will do trials in countries like India, for example, which has developed medical infrastructure and a lot of highly trained professionals, but also a lot of impoverished poor people. You can generate huge numbers of patients in your trial, and then those patients aren't even going to get the drug because they're not in the right market. Pharmaceutical companies' profit margins are gargantuan, suggesting that they should be incentivized to dedicate some of their efforts, more of their efforts, they'll point to whatever small projects they're doing, is not being some anti-free market, anti-capitalist. It is trying to be fairer with the vast resources. Look at the profits that Pfizer has made in the pandemic. KP asks, how fast does your beard grow? Could you create a time-lapse for jokes? I don't really think it needs to be a time-lapse. It could just be real time. Banana, if you could make one quack cure real, which one would you pick? That's a good question. Well, it's obvious, actually. It's got to be Reiki. Reiki is an Eastern pseudoscience where people believe the laying on of hands, or even just hovering above the patient, can control chi, the life force within them. So think about it. If you're using your mind and your hands alone to control some force, some cosmic force that surrounds us and binds us, then you, my friend, are a Jedi. Septimus Productions asks, can we get a coronary artery tier list sometime? Well, I mean, there's technically only two coronary arteries, the left and the right. I mean, even if we broke it down into considering the circumflex and the LAD as separate, then it would be left main and LAD S tier. A tier would be right coronary artery, and maybe F would be circumflex. Circumflex can suck a dick. Matthew Allard asks, if I stent every vessel in my body, would I become more powerful than Superman? I thought you'd be closer to Wolverine, wouldn't you? You'd sort of have metal throughout your body. Although, unfortunately, it's not adamantium. It's almost the opposite. It's very soft, so I don't think you'd be particularly strong at all. But talking of Wolverine, that is actually the name, I promise you, of an interventional cardiology device. It's a balloon. I've got one upstairs, actually. Don't ask why. When you blow the balloon up, 3 metal blades come out of the balloon, and you do this inside the coronary artery for very calcified, tough vessels. So you crack it open with these 3 blades, and it's called the Wolverine balloon. And I've said this online several times, and I've never been proved wrong, so I believe this is incontrovertible proof. Interventional cardiology has the best names in all of medicine because it clearly is a specialty made by 14-year-old boys. Here are all real things that I use on a regular basis. These are all devices that you can ask for in the operating theatre, the cath lab. The Megatron, the Samurai, Judo, Fighter, Marvel, Guidezilla, that's a real one, Guidezilla, Grand Slam, Black Mamba, Green Mamba, the Wiggle, the Mailman, Corsair, BMW, Scion Black. I mean, the list goes on. These are just the first ones that come to mind, but don't they sound pretty damn cool? Riverground asks, with your video about buying human bones and your short about selling human blood, when will you complete the trio with a feature-length documentary about consuming human flesh? Well, I mean, there already is a third part of that trio because I had a short also about the commercial market for human breast milk. I do want to revisit it with a longer video because it's a topic, the sort of commodification of the human body, that I find really morbidly fascinating and makes me quite apprehensive about what kind of dystopian future we might be heading into. Now, we have to call it a day there because this video has got way too long. I've still got loads of questions left. So if you want to keep this going, head on over to Nebula, where you'll find a companion video, a continuation of this Q&A. How far do you think one can go in learning medicine by themselves? What are the odds it will lead to a zombie outbreak? How do things like ADHD affect medical school residency fellowship? I will be focused entirely on the food, and I will annihilate it, and I will leave. Do you ever get tired of seeing a heart go lub-dub? Should doctors believe in evolution? What is your skincare routine? Can you briefly shed light on the big quit going on in the NHS? Well, I didn't think I was going to learn about kangaroo penises today. And you can find more bonus content like that on Nebula from me and hundreds of your favorite indie creators. Just look at all these, all Nebula exclusives. Things like the incredible Battle of Britain from Real Engineering, which has to be seen to be believed. Or, if you're as hooked on geopolitics as me, Polymatter's videos on Asia and Real Life Law's Modern Conflicts are truly top drawer series. And all the videos there are ad-free, so you get a different ending, like instead of this one, where I'm telling you to sign up. And this is all made possible by CuriosityStream, who have an unparalleled range of high-quality documentaries on loads of different topics. This month I've been learning about the slightly beleaguered NASA Artemis mission with my kids, but I've also really been enjoying a new addition to CuriosityStream called The Lost DNA, which uses cutting-edge genetic research to trace Europeans and their development from prehistoric times right through to the Middle Ages. Fascinating stuff. And I'll tell you why I really value CuriosityStream and Nebula, because recently I've really tried to make a conscious decision that if I have a few minutes free, I'm going to not spend it doom scrolling or just wasting my time. And YouTube and stuff is great, but there are loads of distractions. But I know that if I open CuriosityStream or Nebula, I'm going to be educated about something that I care about, that I want to learn about, and I'm going to be entertained. So I have honestly the best deal in streaming right now. I mean that completely seriously. If you disagree and you think there's a better streaming deal, please just comment below what you think offers better value than CuriosityStream and Nebula for a whole year for only $15 or about £12. Access to all of that exclusive content, all of those extra videos, bonus companion videos like my Q&A and other ones I've posted, all videos ad-free for less than the price of a second-hand spleen. So sign up at the link below, curiositystream.com/medlife, and use the code medlife to get that special price, which is 26% off the usual price. So access to all of that content, discover all of those videos, plus you'll really be supporting me too. All that's left to say is thank you very much for 500,000 subscribers.